Hello. In this presentation, I'll be discussing on the OCT interpretation and where do you need to look for, what parameters do you need to consider, and what are the graphs that you need to understand while interpreting an OCT. I have no financial interests in this presentation or in the formats or the models and machines that I'll be discussing, but just for the sake of understanding, you need to remember that currently there are four basic types of spectral domain OCTs available commercially in the market. They are the Zeiss series, which is the most popular, the Heidelberg Spectralis, the OptiView Avanti, and the Topcon. And just like in perimetry, similarly in the OCT also, though the models and machines may remain different, the principles of interpretation remain the same. So let us see how do you interpret an OCT in its simplest form. Now, the OCT analysis basically has three major components. One is the optic nerve head analysis, that is the topography analysis. Then you have the retinal nerve fiber layer analysis, and you have the macular analysis, what we popularly call as the ganglion cell layer or the ganglion cell complex or the GCC analysis. This is the most common one that is used. So I'll use this as a reference for my presentation. This is the Zeiss series printout that we see. No financial interests again. So as you can see here, this is a basic printout which has the optic nerve head and the RNFL analysis of both the eyes. It has the right eye on one side and the left eye on the other, and a combination of both in the center. And along with that is the macular analysis, that is the ganglion cell analysis again of the right eye and the left eye. So let us see each printout segments one by one and what are the things that you look for in each of these segments. So just like in the field printout, also here you could divide the printout into 7 zones. So the first and foremost, as in any other test analysis, you have to see for the general data, that is the patient and the test details, which is given at the top of the printout. It has the basic data for the patient, that is their age, the gender, the test date, what time it was done, the date of birth of the patient, and the registration number. Here it is very important that you see that you are correctly interpreting the printout of the same patient that you are interested in, and the date of birth is accurately mentioned, because just like in the perimetry, the entire analysis will be based on comparison to the normative data analysis. So if the date of birth is wrong, the entire subsequent analysis will also turn out to be inaccurate. And again, it has to be accurately entered, because any mistake in the entry in any of the printouts at any point of time during the follow-up or at the baseline, it will lead to a loss of comparison in the future. So each time the patient's details have to be entered in the same format and accurately without any spelling errors. So this is the general data that you see for, and what was the section that was taken, and for whether for the right eye, left eye, or both of them. In the same sector, you have something called the signal strength or the image quality. Now, this gives you the reliability indicator. That is whether the image scan is reliable and worth interpreting further or not. There would be a different score for different instruments. It could be in the range of 0 to 10 or could be in the range of 0 to 100. Anything less than 5 or anything less than 50 is said to be a poor image quality and it has to be discarded. Then the zone 2 is to be evaluated. As you can see, there are three types of graphs here, or the images that you can see. They are the tomograms and they have to be seen for the segmentation accuracy. The two topmost ones are for the disc in the horizontal and vertical meridian, and their demarcation is basically dependent on the Brooks membrane opening. So if you see here carefully, there is a black line here and a small circular opening. So this is the Brooks membrane opening, which helps to decide the reference line and to demarcate the disc size and the cup size. So, and this third one is the RNFL circular tomogram. So all these segmentation lines, the red ones that you see, they have to be closely inspected to check for any artifacts and for the accuracy. So the signal strength or the image quality and these segmentation images will tell you whether the printout is worth reading and it is considered reliable and if it has any artifacts or not. So as you can see in this image, these graphs that you see, so there are certain deviations of these red lines, and here you can see there are discontinuity and notches, and again here you can see there is some asymmetry. So, and again here the entire image is shifted towards the upper side. So all these suggest that there is irregular placement of the segmentation line, and the entire printout will have some form of artifacts, and it would be an unreliable printout. So the image at all times should be centrally located, and this segmentation line should be very accurate without any deviations on any side. Then after interpreting all this and you feel that now it is worth reading ahead and it is of a good quality and accurate enough, comes the actual rating. So this is the first one that you see, that is the RNFL thickness map, the retinal nerve fiber thickness map. It is a topographical display of the RNFL, and it's typically in the form of an hourglass, and it has yellow and red colors around the disc. And the color coding for this colors is given on the left hand side of this box, where you can see that the blue means that it is the thinnest RNFL, and the more red means it is the thicker. And this basically, this hourglass pattern is because of the thick RNFL in the superior and the inferior poles. So here you have to see whether any hot colors are present or not. If they are present, what are the areas where they are located, what is their size, and if these areas are corresponding with other similar abnormalities in the other parts of the printout or not. Once the RNFL thickness map is analyzed, then you come to the deviation map. Deviation, basically, as the name suggests, that any deviation of this patient's data from the normative database, that is compared to the age-related normative data, that deviation will be picked up here and it will be highlighted. If you can see, it also has an end-faced fundus image. There is a disc and all these vessels are seen. And they correspond to these different types of contour lines. So the red one, the innermost, it marks the boundary of the cup. The black one marks the boundary of the disc, and the purple one, it marks the boundary of the peripapillary RNFL. So the first thing here that you have to see is whether these contour lines, this contour mapping is accurate or not. But sometimes, as in tilted discs, abnormal discs, myopic disc, large disc, this contour mapping itself, that is the disc area marking, may not be accurate, and therefore all your subsequent analysis will also be inaccurate. So the first thing that you see whether this marking is proper or not, and then you have to see for these deviations. That again, as seen, they are in the form of super pixels and they are color coded. So you have to see whether any areas are flagged or not. If they are flagged, what is their color and how large they are and where they are located. So in this, we can see how those hourglass images may change. This is a healthy disc. So you can see a typical vertical hourglass pattern, yellow and red, because of the superior and inferior thick RNFL. And this deviation map, there is no deviation which is seen. Everything is fine. This is a glaucoma suspect. So you can see here slight changes in the red is there. And here again, you can see in the deviation map also, yellow and red areas have started appearing. Coming to moderate glaucoma, again you see the yellow and red are disappearing and more of blue is appearing. So blue, if you see in the legend, it means a very thin RNFL. The micron thickness is very less. So it's gradually becoming more of blue. And if you see in the deviation map, the deviation is increasing. That is, the red color is increasing. And in severe glaucoma, it's almost all blue, totally severe loss of RNFL all around. And you can see in the deviation map also, it's a very hot kind of a map, and it's all red in the superior and inferior zones. And if you can see in the cup and disc margin also, you can see here the margin was good enough, but over a period of time, if you can see, there is hardly any neuroretinal rim which is remaining. The cup red margin is almost parallel and overlapping the red margin of the black margin of the disc. So there is hardly any NRR, healthy NRR which is remaining. So that is how you see the RNFL thickness map and the RNFL deviation map. Then you come to the center of the printout. So here you have different types of parameters, that is the disc and the RNFL parameters. Again, you may not worry about what are the normal values and whether it is in the normal range or not, because again here a color coding is given and you just have to see what color coding does it fall in. In some machines, apart from the right eye and left eye, an additional column is there which gives the asymmetry. So that the difference of asymmetry and its significance would also be marked. So you know whether there is an asymmetry or not. Different types of parameters are there, but the most important that we have to focus on are the vertical CD ratio, the rim area, because we know that the neuroretinal rim thickness and width is more important than just the CD ratio. And you have to see for the mean RNFL thickness. Again, different machines may have a few more parameters also, but these are the ones which are the most important. So again, here you have to see which areas are flagged, what is the color, how many are there, whether they are in both the eyes or any one eye, and if they are in one eye, what is the amount of asymmetry that is there. So what is this color coding that we are constantly talking about? Basically, it's a percentile distribution according to the statistical significance. And it follows the stoplight color scheme. Just like we had in the traffic lights, we have green, yellow or orange and red. Similarly, we have it here. So if it's on the highest level of the normative database, it will be white. If the values fall between 5 to 95% of the normal percentiles, it means that the values are within normal range and it is flagged as green. If the values fall between 1 to 5% of the percentile, it means they are borderline results. So it's a borderline or suspect case and it is marked as yellow. And if the values fall between 0 to 1%, then it will be flagged as in red color, and it means that it is definitely outside normal limits and it is abnormal. Now, what does this gray color mean? As in the previous printout that we have been using as an example, much of these boxes are in gray. Gray means either the values are not compared to the normative database for any reason, or they are lying outside the scope. So there is some abnormality there, which is not allowing it to get compared to a normative database. And what is the reason here? Here, if you see the disk area, it is much beyond the normal size of a disk. It is 3.09, and here it is left eye, it is 3.44. So this is much beyond what a normal range of a disk area would be. And therefore, the entire normative database comparison has not been possible, and therefore it is flagged as a gray color. Below this table of parameters, you have these two graphs. Both of them could be color coded, or it could be in the shade of gray and color coded. The above one is for the neuroretinal rim thickness, and the below one is for the RNFL thickness. The continuous lines there for the right eye, and the hatched line that is for the right eye, for the left eye. So again, both the graphs, you can see there is a continuous line and there is a hashed line, continuous line and a hashed line, that is right eye and left eye. So here, what are the things that you see? One is, of course, because both the eyes are mentioned in the same graph, you have to check for any asymmetry if it is there. Second is, it should follow this double hump pattern. These double humps are there because of the thickness of the RNFL in the superior and inferior poles. So there should be superior thickening should be there and inferior thickening should be there. The sectors are marked here: temporal, superior, nasal, inferior, and again temporal. So that is why it's a T-snit graph. So it should follow the double hump pattern. And third is, you have to again see for the color coding, that is where the right eye graph and where the left eye graph it is falling. So here you can see both of them are falling in the green zone. So it is a normal T-snit graph. And last, at the bottom, you have these circular images. They are the RNFL quadrant and the clock R or the sectoral average. Again, here similarly, a color coding is there based on the p-value and the statistical significance, and they will tell you where in which sector or which clock hour the RNFL thinning is there. Quadrant is basically an average of the entire thing, that is superior, inferior, nasal, and temporal. And the clock hour or the quadrant further divides each zone. Like the superior one is further divided into few clock hours, inferior one is further divided into few clock hours. So you can very specifically find out what is the location of the RNFL thinning and what is the significance. So again, the distribution and this color coding is given here. So you just have to see what is the significance, what color it is, and in which area it is located. And here both of them have to be considered together. That is the clock hour as well as overall the quadrant also. And you see again for any areas which are flagged, how many colors are there and what the colors. Coming to the ganglion cell analysis or the macular analysis, all of us know that because the maximum number of ganglion cells lie in the macular area, and these are the ones that are damaged most earliest, and that is why there is a lot of importance of GCC mapping and analysis in glaucoma also, in typically in those cases which we term as pre-perimetric glaucoma. So you have the ganglion cell analysis, which is there, and just similar to the ONH and RNFL printout, this is a similar interpretation. So you have the GCL, that is a ganglion cell layer, plus the inner plexiform layer. Again, different OCT machines, they have different measurements. Some just include the GCL and some of them include the inner plexiform also. So whatever it is, it would be mentioned there. So you have to see for the thickness, and in the same way, you have to see for the color coding. And it will be, a circle will be marked, and with its center should be at the fovea. So you have to see whether it is properly aligned or not, and what is the color coding. Then after the thickness, you have, or obviously it is compared to the normative database, and you will have the deviation map, where the patient's analysis is compared to a normal. You have to see what are the color codings and what is the area of location. Then you have the sectoral analysis, just like you had in the RNFL. So you have this analysis and you have the color coding. So it will tell you whether it is in the green zone, or it is borderline, or it is red and it is totally abnormal. So again, for the right eye, it would be there, and for the left eye, it would be there. And you have a table of parameters, which gives you the minimum thickness and the average thickness. And again, you need not worry about the thickness for each eye. You just have to focus on the color code, which is the simplest way to know whether it is a suspect case or it is an abnormal case. And just like in the RNFL and ONH printout, we have these segmentation graphs, which tell you whether the segmentation is accurate or not, and whether all the parameters have been measured in the proper format, and whether there are likelihood of any artifacts or not. As I had said in the beginning, whatever the machine and the model, the overall printouts and the interpretation remains the same. So just for a comparative analysis, I depicted 4 different types of graphs or printouts that we see. This one is of the Spectralis Heidelberg spectral domain OCT. So as you can see, it has the retinal fundus image with the contour mapping. Then you have the segmentation graphs to check for the segmentation accuracy. In the center, you have the quadrant and the Glaucoma analysis. You have the T-SNIT graphs, and similarly, you have the thickness grading and the similar color coding which is there. So overall, the placement of the different components is different, but the analysis and the content is the same. Then this is of the Avanti RT view. Again, similarly, you have the thickness map with the color coding. You have this table of parameters. You have the T-SNIT graphs, and you have the average and the sectoral analysis. And again, in the center, you have an additional graph for the asymmetry also. Apart from the right eye and left eye, you have an asymmetry data also. This one is of the 3D OCT 2000 of the Topcon. Again, you have a disk image. That is the actual sectional image of the disk as you would see the fundus. Then you have the deviation map, you have the topography, you have the tomogram to see where the scan has been taken and whether the segmentation accuracy is there or not. This is the RTFL thickness map, and you have the average thickness, the parameters, and the Glaucoma thickness, and you have the different types of parameters. And this is the T-SNIT graph. The only difference here is that this is just for one eye, and a similar one, another eye analysis printout you will have for the other eye. That is, here it is not a 2-in-1, but it's just a 1-on-1 printout. And this is the last one. That is, as we have seen, that is the Zeiss Cirrus OCT, which we have just analyzed and understood in complete detail. So overall, if you see the different models, they have different representation on the paper or on the soft copy, but overall the content that we need to interpret and look for means the same. Whenever you're interpreting, it goes without saying that there would be some obstacles for interpretation and some artifacts which you do need to consider, and that is not part of this presentation. But you just need to remember that there could be artifacts which arise because of the scan acquisition procedure, that is media opacities which hamper the image quality. There could be inherent retinal, chorioretinal, or disc changes which could hamper the analysis, and some conditions like a miotic pupil, poor vision, loss of fixation, nystagmus in the patient, and because of which the eyes don't remain steady, and that is why the machine is not able to capture a good quality image. And there could be, of course, obstacles and artifacts which relate to your own interpretation. That is, if you have not seen the scan quality or any variability is there, if the normative database is not there for interpretation and comparative. And finally, you have to consider the clinical correlation. Because the most important thing here, if you have realized from the entire interpretation presentation, that is, it just tells you whether it is abnormal or not, and whether it deviates from the normative database that is there. So the first and foremost, you have to keep in mind that what is the normative database for that machine and model that you are using. Usually it is from the age of 18 to 84 years, in some it is still 94 years. So if you are doing it for a pediatric patient or a very elderly patient, because in most, as I said, it's just till 84. Then again, there would be no normative database, so all the analysis would be wrong. Second is you have to consider that it just tells you whether it is abnormal or not, whether it is due to glaucoma or whether it is due to some chorioretinal abnormality or some congenital problem and disorders. It does not tell you. So that you will always have to correlate it clinically. And any inherent abnormalities which lead to poor quality scan, artifacts, and segmentation errors all will ultimately also influence your interpretation. So you have to correlate it very accurately with your clinical findings and the DISC findings. So finally, to conclude, always when you're doing a progression analysis, use the same machine, just like in the perimeter, and always use a reproducible image quality to have a meaningful evaluation. Know the limitations of your machine and what are its characteristics. What does it actually do? What type of scans does it take? Keep in mind the common sources of error and artifacts that may influence the interpretation. And most importantly, as with any other test, always correlate clinically and do not initiate your treatment or base your clinical and management decisions just on any single printout or any single. And these are the important references that you could also have a look at, and from where I have taken many of the printout images for my presentation. Thank you. Hope it helps.